So I'd like to introduce our first speaker this afternoon, Melanie Nana. Melanie, welcome. Melanie is a consultant. I think last time I introduced you, I think you weren't a consultant, but irrespective of that, for years, Melanie's been sort of the expert on hyperemesis, and I think you also wrote most of the college guidance, if not completely. I know it's an ultrasound meeting, but I think this is an extremely important talk, because I think the management of hyperemesis, despite the fact that we do talk about it a fair amount, is generally not great. And there's still a reluctance sometimes to treat people appropriately, give people ginger biscuits, that kind of stuff, but I'm sure we'll hear about that. Go off and so forth, measure ketones, all the sort of stuff I can see Melanie getting wound up about as I mentioned them. But no, so it's a very important topic, and one which all of us face when we're working in early pregnancy. So Melanie, thanks very much for giving up some of your Saturday to speak to us, especially on the obstetric side of things, because as a gynecologist, you did join the dark side, as I always describe obstetrics. I was devastated to give up obstetrics a few years ago. I cried for about 3.5 seconds. Over to you.
Thank you very much, and thank you for the introduction. I'm actually a physician by background, so I'm even further out than obstetrics, so I'm really a fish out of water, but I'm delighted to be here. So I'm going to talk a bit about hyperemesis. I've been asked to focus a bit on about what causes hyperemesis and some of the management strategies. So I'm going to start with the definition of hyperemesis. So as you will all know, working in early pregnancy, 90% of women will have some form of nausea and vomiting in pregnancy. 3% of those women will have a severe form of the disease, and of these 3%, 1 in 5 will have symptoms throughout their entire pregnancy. So there's a common myth that things get better after the first trimester, but for 1 in 5 of the women with the most severe disease, they will vomit until term. In 2021, there was an international consensus definition which demonstrated that we should have nausea and vomiting, one of which must be severe, so that can be just severe nausea, starting before 16 weeks gestation, which result in an inability to eat or drink normally and limit activities of daily living. Note that there's no mention of ketonuria, no mention of weight loss. This is about how this affects this woman's ability to function and eat and drink normally. So I want to share with you some unpublished data which hopefully will help us understand the demographics of the women that we're looking after in the UK, and particularly in South East London, where I work. So this was a study where we looked at nearly 900 women who had been admitted to hospital with disease that was severe enough to need an admission. And we compared them to about 55,000 pregnant women in the background South East London population. And you can see here that in our population, 17% of women are made up of women of black ethnicity, but nearly 40% of the women admitted to hospital with hyperemesis were women of black ethnicity. Now, there may be some genetic role here, but I do not believe that that's the whole story, and we have an access problem. So when we're thinking about the women that we're treating, think about the women that manage to get into our clinics, the ones that turn up to the early pregnancy units, and then just have a think about all of the women that we're not seeing. So in terms of the causes, you'll remember from your medical school days or midwifery school days the role of HCG. It makes sense. It goes up in early pregnancy. Symptoms are typically worse in early pregnancy. But you may be aware from some of the news articles and the recent literature that there may indeed also be the role of GDF-15, which is a placental and appetite hormone. So the way that they identified this was very clever. So Marlene Fager, who works in North America, was doing some work with one of the ancestry groups. So you know these ancestry apps where you can give a saliva sample and find out your long-lost relatives that you didn't know about. So they have a similar one in the States, which is called 23andMe. And she contacted them and said, could you put a question into your screening questionnaire that says, did you vomit in pregnancy? And when they did that, they were able to therefore get the genetic material of thousands and thousands of women. And one of the hits was GDF-15, which is a gene which is involved in placentation, appetite, and cachexia. So how do we think it works? Well, we know that all placentas produce a load of GDF-15. And this binds the G-FRAL receptor, which is located in the area postrema of the brain, which is otherwise known as the vomiting center of the brain. So when it binds that, it can cause vomiting and appetite suppression. Now, this is the same area that chemotherapy agents bind to the hindbrain that cause the emetic effects of chemotherapy agents. And we wouldn't underplay the vomiting that is associated with chemotherapy. So I think it gives us some insight into why the women feel absolutely so dreadful and potentially why steroids work. So there have been demonstrated to be GDF15 mutations in women with hyperemesis, and we think that these women have probably less GDF15 outside of pregnancy. So we all have some GDF15 outside of pregnancy, and therefore it's a sensitivity to the increased amounts of GDF15 when the woman becomes pregnant. And in some mice studies, there have been some suggestion that we can desensitize the system so that we might be able to improve the outcomes of the women once they become pregnant. Now, there aren't any trials at the moment to look for treatments, but there has been some thoughts around whether we can do some preconditioning by refashioning drugs rather than making new drugs in pregnancy, which of course we know takes a terribly long time. So there has been some thoughts around the fact that metformin, which of course cheap, safe, drug that we already use in pregnancy with a lot of confidence, could reduce the sensitivity to fetally derived GDF15. And there haven't been any prospective studies yet, but what they have done is look at population studies where they've compared 80 women who had metformin for pre-pregnancy polycystic ovarian syndrome, for diabetes, and they've compared them to about 4,000 women who are unexposed and about half of the rates of hyperemesis patients in the group that were taking metformin. So it didn't reach statistical significance, and it wasn't powered to that because they've used population data. But I think there's certainly, considering the availability of metformin, the potential to do randomized trials. The other option that they have is to try and block GDF15. And there are certainly some studies that are going to be coming out of Cambridge and the States, like they're collaborating. But there's obviously had to be some careful thought around if your placenta and your fetus produces all of this GDF15, what are the consequences of directly blocking that, and what are the roles of it in terms of a healthy pregnancy? So let's watch this space. So in terms of the initial clinical assessment, in terms of the RCOG guidance, this is what we've recommended. So in all patients, this is a diagnosis of exclusion. So you need to have the typical symptoms. This is obviously more compelling if someone's had a history of hyperemesis before. History repeats itself. 70 to 80% of women who have hyperemesis in one pregnancy will get it in the second. And typically I say to women that history repeats itself. So if you vomited 20 weeks, it's very likely you vomit 20 weeks again, 30 weeks, 40 weeks, so on and so forth. But in all women, they should have a urine dipstick, full blood count, glucose, electrolytes, and an ultrasound scan, if possible, in an early pregnancy. Now, this doesn't stop you giving treatment before then, but we know that increased placental mass, for example, is associated with more vomiting, and you want to make sure there's a intrauterine ongoing pregnancy. I don't need to tell this audience that. But why do we do the other things? It's not because we're looking for ketones in the urine. It's because we want to rule out some of the myriad of other underlying causes of nausea and vomiting of pregnancy, none of which are particularly common, but we don't want to miss them. So the urine dip is to rule out a urinary tract infection, common things being common, full blood count infection, glucose hyperglycemia, renal, acute or chronic kidney injury can contribute towards nausea and vomiting of pregnancy. And only in those who have refractory disease, we would recommend doing the additional tests to rule out hyperthyroidism, liver disease, pancreatitis, so on and so forth. But one thing that I would encourage you to look out for, and something that I've diagnosed now 3 times in the last 5 years, are gastric cancers. The rates of cancer in pregnancy are on a steep upward trend, and gastric cancer particularly presenting late, because women will think it's quite normal to have a bit of epigastric pain. Perhaps when you get some heartburn, you might feel sick in early pregnancy, and we often pick up these patients quite late. So you see so many of these women in early pregnancy. If you get a spider sense that something's not quite right, just think, send a full set of bloods, check their liver, and then perhaps think about endoscopy. So in the interest of time, I'm not going to go through all of the systemic effects, but we've summarised this in a recent Lancet review on hyperemesis, which was published earlier this month. And this is the figure that we've designed, basically just to show that this is a multi-system disease. It affects almost everybody's system, and it is associated with the left-hand side with all of these symptoms or characteristics. And on the right-hand side, all of these here are the life-threatening complications, which do sadly still happen in the UK. So I'm not going to go through all of them, but I will touch on a couple, because having told you to suggest that we do thyroid function tests, we've got to expect that they then come back abnormal. So your HCG binds your TSH receptor, which makes your T4 go up, and then the negative feedback is still in play and your TSH goes down. So you'll know that that's very common in early pregnancy. It's more marked in hyperemesis. So we would expect that 50% of women will have abnormal thyroid function tests. I don't do anything about it, particularly if they've got no symptoms. So the difference between thyrotoxicosis and biochemical thyrotoxicosis that you see in early pregnancy is that the biochemical women typically don't have any symptoms. They don't have the tremor, they don't have the palpitations. Very, very rarely they might if the T4 is extremely high, but not often. So I usually think treat the underlying disease, repeat the thyroid function tests in 4 weeks' time. The next is to mention the liver enzyme disturbance. So I was very fortunate to also write the European Guideline for Liver Disease in Pregnancy. And in that, the hepatologist interestingly asked us, would you comment on hyperemesis? Because we get a huge number of patients referred with abnormal liver enzymes and the underlying disease is HG. So again, 50% of women will have an abnormality in their liver tests, usually the ALT, but also the bilirubin, the amylase, probably as a result of starvation. There are no cases where this has resulted in long-term adverse outcomes. So what we've suggested again is treat the underlying disease. This is an extract from the European guideline, and you can see that what we've said is that only if the ALT is above 5 times the limit of normal, do a primary liver screen. Unless obviously you're really worried that something doesn't sound right from your history taking. But if the ALT is 300, you treat the disease, it will get better. We see cases where the ALT is 1,500, and within a short matter of weeks of treatment, it does start to come down. So the next thing that I wanted to highlight is the VTE risk, because this is a huge problem, and it's a huge problem in early pregnancy. So VTE is now the leading cause of death as per the Embrace report. And you would anticipate that the deaths happen in the postnatal period or towards the end of pregnancy, but look at this uptick in the first trimester of pregnancy. So 16 women died in the first trimester of pregnancy, of which 6 out of these 16 women had hyperemesis. These women are lying at home, immobile, not seeking treatment, and dying of VTE. GPs, it turns out, can't prescribe VTE prophylaxis. They might not be coming to our early pregnancy units. They certainly don't come to my obstetric medicine clinic at that time. So they're very, very high risk in the first trimester of pregnancy. So if you see them, just think, if they've got hyperemesis plus one other risk factor as per the RCOG guidance, so that's immobility, being overweight, previous history, it's safer to give some VTE prophylaxis. And I'm not going to go through all of the life-threatening complications because we haven't got that much time, and they thankfully are rare. But I will mention how we prevent some of them in the management section. But I do want to comment on the fetal outcomes, because I think part of the reason that women with hyperemesis get such a bad deal is because they're told it's really awful to vomit in early pregnancy, and yes, you feel really sick, but at least it's a sign of a successful ongoing pregnancy, and at least you're not having an ectopic and you haven't miscarried, so on and so forth. So, and your baby will be absolutely fine because they take what they need, but it's not categorically true. And we know from, again, this is some of Marlena's work, who is the same person that's done the GDF-15 work, she's busy, that children born to women with severe hyperemesis have a 3-fold increased risk of developing a neurodevelopmental disorder. Obviously, the pathophysiology is very unclear, but importantly, when they've done the studies, it hasn't been associated with the antiemetic therapy. This was the children at 8 years old. She then followed them up to 12 years old, at which point 8% of them had a diagnosis of autism spectrum disease, which is above the background population. Now, whether that is related to socioeconomic background, whether it's related to nutrient deficiencies, whether it's related to bonding and everything else that comes with the psychological impacts of this disease, we're not sure. But it's been demonstrated by a number of different groups and in meta-analyses now. So I think we should be a little less confident to tell women not to worry about it, and more focused on how do we treat these women properly. So I'm sure many of you have been to these courses before, so I apologise and don't apologise for going again through the mental health complications, because this is something that has really struck me over the last few years. In a study of just over 5,000 women back in 2021, we demonstrated that 5% of women with this disease will terminate a wanted pregnancy, and 6.6% have regular suicidal thoughts. And now I'm an endocrinologist by background, so when I came into obstetric medicine, I found this really, upsetting, but surprising, perhaps, I guess. And then I have been involved in the National Charity for Hyperemesis and have been involved in some advocacy work that a family have done from a woman called Jess Cronshaw, who her family are raising awareness of the fact that this lady was a woman who was a primary school teacher. She had no mental health problems. She suffered with very severe hyperemesis, couldn't leave the house, very, very isolated, had not previously suffered with her mood, and went into a obstetric unit and was told by a midwife when she asked for a repeat prescription of her first-line antiemetic, you will already have harmed your unborn child by taking this drug. And she hung herself that afternoon. So the numbers in this study are numbers, but there are people at the end of all of this, and we just need to make sure we're doing what we can to protect them. Some of the risk factors in this study that led to some of these adverse outcomes included basically being treated badly by members of staff, but also not being able to access treatment appropriately. And again, I'm not going to go through all of these in detail, but I do want to highlight some of this qualitative work which we did. Just over 5,000 of the 5,071 women in the study wrote in an open box feedback about their experience, and we did a qualitative analysis. So the terms that come up here are the themes. The number of women that mentioned these themes are the numbers in the brackets. But women being scared and alone and attempting suicide because they can't find another way out. Women not being taken seriously until they've lost 2 stone. Families and friends accusing women that they will have harmed their children. So imagine the woman feels guilty enough, and then they go home and their families do not understand the condition. It's not a well understood condition. And then they're meeting healthcare professionals that also don't understand the disease. And bear in mind that 3% of babies are born abnormally in the background population. So some of these women who are taking safe antiemetics will have adverse outcomes. And if we don't counsel them in a confident way that reassures them that there are wealth of safety data about the antiemetics, they're carrying along this guilt for the rest of their lives potentially. And many women ask me if they can be booked to have a sterilisation postpartum because they cannot go through it again. So in terms of offering medication, we know that women who can't access medication have higher risk. That makes sense. But I think we can't rely that everybody knows what they're doing. And if people are anxious about prescribing, we do this day in and day out, but that's not the case for primary care colleagues who are managing a whole host and variety of different patients. We don't have their expertise. They don't have our expertise. So if you have the opportunity, please don't send them back to their GP to get this sorted. Prescribe something there and then arrange for them to have some follow-up. Okay, I'm going to spend the rest of the talk talking about the management. So this is an extract from the RCOG guidance. You will be familiar from the 2016 guidance with these first-line antiemetics. Basically, they're antihistamines, cyclizine, prochlorperazine, promethazine, chlorpromazine. The new addition is doxalamine and pyridoxine, which is a combination of antihistamine and vitamin B6. Licensed in the UK as Zomvia. It's a licensed medication. I personally don't believe that it's superior to any of the other first-line antiemetics, but as women are individualised beings, some women will respond better to others. I think it should be an option. And the time that I do use it is in women who I know have had a very severe history of hyperemesis and then are planning a new pregnancy, because there is one small study which showed that if you give the Zomvia from the point of a positive pregnancy test, so don't wait until they're vomiting, you can reduce the severity of symptoms in the next pregnancy and the number of weeks that they vomit. Whether that would happen with ondansetron metoclopramide, probably it would. But the study's been done with this. And as we know, there are more actually safety data for this drug than there are the others because it's been used so widely internationally. It's a good, safe option. Second-line antiemetics include metoclopramide, domperidone, and ondansetron. That hasn't changed. And third-line steroids. So this is the small study that I mentioned in terms of preemptive care. I wouldn't usually base my practice on 31 patients, as I'm sure you don't usually, but in the absence of any other evidence, and having now looked after probably 100 women who've had pre-pregnancy counselling for a severe history, who have found benefit in having early access to antiemetics, I don't think it does any harm. Other myths are that metoclopramide can only be prescribed from 5 days. I don't need to teach this audience that, but you will find that if women go back to the community, it will be stopped after 5 days. And that's because of the rare risk of extrapyramidal symptoms, which, to be fair, is more common in younger people than older people, but the risk is less than 0.2%. And the symptoms typically start within 24 to 72 hours with some abnormal movement. So it makes absolutely no sense to me to stop it at 5 days, because the majority of them would have had the symptoms already. If they do get these symptoms, they can stop it. Most of them will just resolve on their own. If not, IV bentropamine is usually very effective too. So the new guidance is very, very clear that we should be giving metoclopramide on the balance of risk and benefit if it's useful and helpful to the woman for more than 5 days. Did that have the, yeah. Oh, sorry. That's the slide that I was meaning to show you. Okay, so ondansetron safety in the first trimester. So this has been a real headache, hasn't it? Because we were all prescribing it merrily until the EMA warning came out about 5 years ago that said it causes cleft palate. And that was based on one study which showed that it might increase. There's 3 big studies. One of them showed a potential association with cleft palate. The background risk of cleft palate in the UK is 11 per 10,000. And if we believe that study, which I should remind you, compared women with hyperemesis who were taking this drug with women who had no vomiting at all that were pregnant. So how do we know that it wasn't the micronutrient deficiency or the sickness or anything else that comes with the disease? Increased the risk to 14 per 10,000. This infographic from the Irish Medicines Agencies I've actually included in the guideline in the appendix, because it's very rare that I talk this through with a patient and they don't take the drug. What I do is make sure I prescribe it with some laxatives, though, because you can take away the vomiting and give them a new problem if you make them very constipated. So don't forget to co-prescribe. In patient management, so any patient who has what we call a puke score, so that's a way of trying to identify the severity of disease. It's very simple. It's a 15-point score, and it's based on number of times vomiting a day, number of times dry retching a day, and the number of hours spent nauseated, plus any complications. So that's a urinary tract infection because you can't take your treatments down. That's because you have a chronic disease like epilepsy or adrenal insufficiency and you can't take your routine medications. Clinical dehydration, weight loss, and like I mentioned before, comorbidities. So when you bring the women in, which IV fluids do we give them? I would recommend normal saline or sodium chloride, not because there's any good randomized trials, but because these women are hypokalemic, hypochloremic, hyponatremic. So it makes physiological sense to give 0.9% chloride with potassium replacement. Women in this country are still found dead in bed every year, presumably from electrolyte abnormalities with this disease. So we just need to check the potassium. Avoid dextrose because that can precipitate vernicase encephalopathy. When you are thiamine deplete, when you give a big glucose load, you basically can deplete your existing stores of the thiamine, which is required to break down the glucose. So if someone's in a very, very thiamine deplete state, and then you give them a load of dextrose because you think they could deal with the sugar, you can do harm. And in a systematic review of all of the cases that have been published on vernicase encephalopathy in the context of hyperemesis, 15% of them had been given dextrose beforehand. So let's not do that, unless they're in the late third trimester and they've got starvation ketosis, which is obviously a slightly different story. Daily monitoring of electrolytes, and we've talked about VTE prophylaxis. These are treatment flowcharts that you'll also find in the guidance. Now, essentially, they are, we have just basically made an algorithm where you can initial assessment, diagnosis, management for general practice, ambulatory care, early pregnancy, and if I had more space, there would be the inpatient gynae ward one. They basically all say the same thing, but with some caveats to where the patient's been looked after. And that's because we know these patients bounce between different services. So once they come to you, then they probably come to me, and then they go to the ED. And if we've all got a different plan, not helpful. Now, the Association of Early Pregnancy Units, co-badged, the Association of Emergency Departments or Royal College, co-badged, the RCOG guidance, the GP practice would not. So they supported it but would not co-badge it. So as a result, there hasn't been much. It's been difficult to infiltrate the GP community to know that these exist. So what we've done subsequent to that is updated the NICE CKS guidance, which is the go-to place for the GPs. But I often just print this out for patients if I'm going to send them back to the GP so they can say, this is the treatment I've been started on, and look at this handy guideline. So just before I finish, I'm actually running ahead of time, but I think that's probably not a problem today. I'm going to burst a couple of myths, which hopefully you've heard me tell you about before. Prof. Bourne obviously has, because he's already mentioned the ginger. Please don't give women ginger. This is because not only is it not helpful, it might be helpful in some patients who have very, very, very mild disease. It's certainly not helpful in moderate or severe disease. And in fact, it causes reflux. So if you survey all of these women who are taking it, they just say, well, that really didn't help me because now I've got terrible reflux, which I probably had already. So, and it's also just entirely undermining to suggest that we wouldn't do that for a woman who's got chemotherapy-induced vomiting. Let's not do it for these patients either. And then I'm going to finish with a little bit of endocrinology for you all, because I'm sure that's exactly what you need on a Saturday afternoon. Ketones are a good measure of hydration. Like, hopefully nobody believes that anymore. So we produce ketones when we don't have enough carbohydrate. So there is an absence of carbohydrate substance. So we go into our anaerobic pathway. We start to break down adipose tissue that makes free fatty acids, acetyl-CoA, which then goes into the citric acid cycle so that we can make our energy. And the byproduct, when this is now saturated, are ketones. So tell me where in this cycle there's any evidence of dehydration. So people who are saying, well, you can't come in for IV fluids because you're not dehydrated and you don't have ketones. I mean, I don't know what to say, but it doesn't make any sense. They're two completely different pathways. The only way that we can diagnose dehydration is from clinical examination, which we all can do. So if you hear the word ketones, we've actually command find and removed ketones out of the entire guideline so that they don't even exist. But let's all spread the word. Okay, so hopefully I have convinced you that untreated hyperemesis carries a risk of morbidity and mortality for both the mother and the fetus. We all share the responsibility for identifying and treating these women. Guideline recommended treatments are safe in pregnancy, and there are lots of unanswered questions about the physiology and underlying mechanisms, which I think we can be excited will change in the next few years. But in the meanwhile, there's absolutely no excuse for not listening to the patients, being kind to the patients, because I think that's the first way that we're going to make a difference. These are my PhD supervisors and also co-authors of the guidelines, and thank you for having me.
Melanie, thank you very much. As ever, fantastic talk. Any queries? A lady there.
Melanie. I just want to ask a question about cyclical vomiting syndrome, because we recently had a few patients who are struggling with this syndrome outside of pregnancy, and as soon as they started pregnancy, it became even worse, or hyperemesis got on top of it, and it's absolutely unmanageable. So I just really don't know what to do with them and how to help them.
Really difficult. I mean, it's an unmanageable condition outside of pregnancy, isn't it? It's very, very debilitating, and women come into the ED repeatedly under the medical intake with this problem. I think you then add in the pregnancy hormones and everything else that goes with it, and it becomes very difficult to manage. There's no magic recipe. They're likely to have difficult to manage disease, and I just do the same as I would do if they had hyperemesis, because ultimately we don't want them to be vomiting. We want them to have some nutritional intake. And so I would just follow the same algorithm and sort of try and stick it out and hope that if their natural progression of any additional vomiting of pregnancy might get better mid-trimester, towards the end of pregnancy, they might get a bit better. But I think that if you've got an underlying tendency to have vomiting syndromes, it's really hard.
Thank you.
Just there first.
Do you find that there's an issue with regards to Zonvia being available formulary within certain trusts compared to having it from the GP? In my previous trust, that was quite an issue. Women would come in and say, Zonvia's worked for me, but we don't have it in our formulary.
Yeah. I mean, it's an equity of access, isn't it, ultimately? I empathise with the patient. I think that the more and more trusts are able to access it now, and once it had gone into the guideline and then the NICE CKS guidance, I think there's more trusts putting it as their green in their formulary. But if they have severe disease, that drug alone will not work. And I do not believe also that the combination of other first-line antiemetics doesn't work. So I try to move away from this, okay, we can't get access to this drug, and think I actually combine 2 antihistamines. I give Bucostem, which is buccal prochlorperazine. I give that first, and I say half an hour later, take some cyclazine or wherever it might be. And then I just say that it's very, very normal for me to have to put women onto 2, 3, 4 different antiemetics. I don't stop the first line ones. I add them in because I believe that there's some synergistic benefit. And I just up titrate them on other stuff if I can't get access it. But a lot of work is going on in the background to try and make the access fair. It's expensive, ultimately, but you know, yeah.
So do you add in a second line one on top of the first one and just keep?
Yeah, I
adding?
mean, I saw a woman in clinic yesterday who's had very, very severe disease in the past, and I gave her some Bucostem and some cyclazine, and I said, I'm going to call you next week, and if you haven't got better, we're going to add in some metoclopramide. I like it because I think it's good to have a prokinetic, and then I add the ondansetron in. But I don't wait 3 or 4 weeks for these women to deteriorate. I just give them all, and I say we can always come back if we need to.
Thank you. Siobhan?
Thank you very much. I was going to ask a completely different question. So, as you know, in the UK, obstetrics and gynecology is separating. Tom put it really eloquently.
Joking.
And so, but that separation is being worsened by the use of electronic notes. So, at the moment, I don't think that in most obstetric units we use hyperemesis as a indication for serial growth scans. So, do you think it should be an indication? And how are we going to get the information that had hyperemesis into the obstetric?
Yeah, great question. I think that I'm not an obstetrician, okay, so I'm not going to comment too much on baby's growth in this audience particularly. But in the study that I showed you, the population study that we've done, 18% of the babies in the hyperemesis group were less than the 10th centile. So we know this not from just our work, but multiple papers in the literature now. And so I think that it is an indication in the guidance even to do serial growth scans. So yes, I do think they should have them. And how we get that across, I actually, unpopular opinion probably, but I just think these patients should be looked after in one place the whole way through their pregnancy. Like, I needed to admit someone this morning, but she's not quite 18 weeks, so she can't go to the maternity assessment unit. The early pregnancy unit can't make
Oh, you're getting into deep water now.
Well, it's a fact. This is what happened to me today. So, you know, I don't, it's not fair on the patients, is it? We need to just have a place to put them.
It's ridiculous, isn't it?
It's quite ridiculous.
We see this false different, I mean, sadly in miscarriage as well, where people suddenly have everything thrown at them at a certain point, but below that level.
Yeah, and you get used to your early pregnancy unit, and then you're suddenly ousted into... Anyway, I won't comment because it's clearly a political thing, but that is my lived experience.
You talked about a couple of situations. We talked about growth, and I think you'd mentioned, is it autism possible?
Yeah.
I mean, what's the issue? I mean, do you find that there's a risk of autism or whatever, even if it's treated effectively? Is there an underlying issue?
Yeah.
Or is it the fact that they're nutritionally deprived? In which, is there any clue mechanistically what's going on?
Yeah, so no, there isn't. And my PhD is exploring whether nutrient deficiencies might contribute towards adverse neurodevelopmental outcomes. So we're measuring the nutrient status of all these women. But in truth, while we're doing brain imaging of the babies and early assessments, it's going to take 5 years. 8 years to be able to tell us for sure. I think it's probably a combination. I don't believe that it will be entirely that you can combine a few micronutrients, replace them, and then I think it's a dreadful pregnancy. The risk of postpartum depression is really, really high, even in women that have proven to not have any mental health problems before, whether that's just because they're so miserable because of the hyperemesis pregnancy, or whether they're women who are prone to develop postpartum depression and that's an extra hit. I think there's a combination of that, socioeconomic background, bonding, and maybe some other biological causes, but it's not clear.
It's be difficult. And in terms of GDF-15 and so on, I mean, what's the candidate treatment there? Because you're looking at a receptor, and also then if that's the case, would that work in terms of? I mean, it might be quite. The situation in oncology is very different because obviously you've got a pregnancy. So
I don't. It's really difficult. They have designed a blocker, but we actually have been cautious about it because we don't know what the implications of blocking GDF-15 are.
Because there's a normal.
You have so much of it. The trophoblasts produce it in so much abundance. So, and the other thing to remember is that as with any genetic mutation, I think it's something like 2 or 3 in 100 women will actually have that mutation. So I don't think we can lose sight of the fact that we need to look for treatments widely. But the studies are ongoing. They are recruiting, and we will have an answer one way or another.
But it's quite a breakthrough, though, wasn't it? In a sense.
I mean, nothing ever happens in hyperemesis, so I was
pretty well. I mean,
delighted.
it's making the front pages of newspapers.
Yeah, it was.
Any other no other questions, I think. I mean, thank you very much,
Pleasure.
basically, and for all the work you've done on this, because you've really kind of highlighted a really, really important area.